Okay, and next we're going to have a presentation from our very own Dr. Adrian Waterman. So Dr. Waterman is a graduate of the University of the West Indies in biology and chemistry, and he then went on to pursue a career in medicine. On completing his MBBS in the year 2000, he entered the specialty of anesthesiology and intensive care at the UE. Due to his working experience in Wales, he developed a love for pain management. He recognized this especially in the context of patients suffering with cancer pain. On completing his doctorate in medicine in anesthesiology and intensive care, he undertook a consultancy in St. Lucia and then went on to work at Harley Street Clinic while doing an honorary fellowship in pain management at Queen's Square in London. Please welcome Dr. Waterman as he gives a presentation on the non-surgical management of pain in endometriosis.
Pelvic pain in addition to endometriosis, but we do know that in terms of pelvic pain, it can extend to several different areas. I'll try to be hopefully brief and hopefully sweet in it. It may get a bit technical, so feel free to stop me if I get all nerdy. Ask as many questions as you want. I think this before we mentioned by the other doctors, medical opinion. In terms of a diagnosis of pelvic pain, it can be very complex. Your pelvis is basically, if anybody touch the top of their hips, feel like the bones, and then just below it, what we really call our serious pelvic anatomical pelvis for us in the medical field. It contains a whole set of different sort of organs. For men, of course, we're lacking quite a few of those, but for women, you will have the uterus, the ovaries, fallopian tubes, etc. And then extend down below, basically the exit, you will have, of course, the tube and the vagina, and of course the vulva, etc. But in relation to endometriosis, we probably have a definition for endometriosis. Simply put, it's basically tissue that's supposed to be laying inside the uterus that is occurring elsewhere. It's abnormal, and it shouldn't be there. And for the description of this sort of endometriosis, it usually leads to pain not at what we call it menarche or the beginning, the first instance, but leads to it later on as such. And there's a lot of so-called theories behind why people will have endometriosis. But I leave that to the gynecologist. He's far more au fait with that. Yeah. When it comes to systemic examination, in fact, going back into history, when you present to the doctor, we'll be asking you a whole set of questions. Questions pertaining, as you realize, to basically when your menses are, how heavy they are, how much juice, the pain associated with it. And then it may seem sometimes when we get a little bit personal in terms of maybe asking in relation to your sex history too as well. And this because, unfortunately, these abnormal deposits of the endometrial tissue outside can occur in areas where it can make sex difficult and cause severe pain. So all these things relate. And then there's another issue that's important. Again, coming back to the complexity of pelvic pain is that because structures are so much packed into that area that sometimes what we may think it is, it may not be, because there are other tissues in there that can present similarly. Likewise, your spine can contribute to pain coming from down there. Your uterus, basically a tube that runs from your kidney down to your bladder too as well. The ovaries can be the issue separately from the endometriosis. So you have a whole set of different things that lie in that one area that sometimes can fool us to what is actually causing it. So that's why history sometimes is extremely important, followed by an examination. Again, the examination, you may be surprised, some doctors may do what we consider a systemic examination, where they examine you from head to toe. And that's because there are different reasons, again, why you may be having pain down below there, and you can't basically just believe it just lies there. The funny thing about endometriosis as well, is endometriosis can occur even in other areas outside of the pelvis as well, right? That examination may include a very personal examination. The gynecologist, again, is why I tend more rely on the gynecologist report, because in terms of some of these examinations, they're extremely personal, and sometimes there's the impact, certain psychological reasons, which the psychologists would have highlighted, which can impact in terms of being you presented to somebody new during this examination. So there's a lot of comfort and a lot of relationship you have to build up when it comes to sometimes this pelvic examination. Lab tests, again, they're directed by the history and our clinical examination. We don't send you willy-nilly. There's not the practice of just saying for a whole series of tests. The tests are usually directed at what we think it is. If the tests come back negative, it means we make the next step. So what the doctor will try to do is, of course, entertain the test that gives the best results, and of course, we need the economics of it. So we're not going to send you for a complex, and we call it MRI, which is like over $1,500. Then you can do an ultrasound, which is much simpler to give quicker results. So we do a stepwise move. Imaging studies, I just mentioned the ultrasound and MRI is needed. And then, of course, going back to the surgeon, in some cases, the definitive diagnosis, the surgeon basically does laparoscopic surgery. These days, thankfully, we've gone past the era of whereby we're making a huge incision to take a look. They make the whole surgery, as they would say these days, which basically leaves very small scars or hardly scars. And in our population, well, I'm a black person, so I'm much more prone to scars than most people. Not that he'd be doing a laparoscopic surgery on people with endometriosis, but as a man, I can have my own set of, because the men here, youths also can have chronic pelvic pain, not related to endometriosis, of course, but prostate and other issues. So this is what it's related to in terms of how the endometrial tissue that's supposed to be lining the inside of the uterus can occur outside. And so it can occur even within the walls of the uterus, and that also causes a special condition which is related to adenomyosis. And that could cause severe pain and bubbliness in the uterus too as well, and other issues. So these structures too as well, outside of endometriosis, as I said, independently they can cause their own pain issues. So that's why sometimes we can have issues in separating them, and sometimes their management is a bit different. As mentioned a bit earlier, sometimes it occurs outside the pelvis. It can actually occur in your lungs. Some people can have, coming around to their menses, can we actually start coughing blood, in our country we call it hemolysis. They start coughing up blood on a sort of a cyclic time period. And sometimes they can occur even along the ureters again and cause bleeding from the ureters. So the person starts to urinate blood around certain time. And what the surgeons will mention to you, importantly, is that you keep a sort of diary of relation to the pain, so that when they look at the diary, they can relate to see if it's a cycle. So within like basically 3 months, they will pick up, but this seems to hit intensity or seem to get pain around a certain period of time, and that provides also the appropriate diagnosis of what is going on. Well, with the medical management, I'm not touching on surgery. So basically, pain management is along my lines, and one of the things not along my lines is in terms of fertility. A young lady, in terms of sometimes the medical management of her endometriosis, she's going to be concerned about her fertility for many different reasons. She's starting a family, etc. So these are some things we have considered. Now, sometimes there's one thing that must remember in terms of management of chronic pelvic pain. Of pelvic pain. I should have mentioned chronic yet. That in terms of it, it sometimes requires a multiple disciplinary approach. So that's why, and I must commend Dr. Barker on this, I very much in the English system of implementing or involving the psychologist earlier than later. Involving other people too as well, be it people from the other pain specialties, be it the urologists, etc., be it the gastroenterologists, bringing them early rather than going through everything and then saying, well, I give up, let me try to the next guy and down the line. So it's very good sometimes when you see that we pull in people earlier. All right? They're not trying to make you poor. We got Trump for that. So now the whole thing about, especially when it comes to endometriosis, you're feeling me, they like really quickly, I don't know why. But yeah, I have my kingdom for glass. So the key thing about it is, in terms of endometriosis, related to endometrial tissue, is that it responds to hormones. It responds to the sex hormones that you produce, the progesterones and the estrogens. And knowing that is one of the key approaches to it. Forgive me a minute. I hear this called Boomston wine. Sorry, I only learned that yesterday. So your treatments. Again, medically, we like to approach it, we have to think of you. People always have it thinking, man, you go to the doctor's office, they just want to charge me big money, make money over you. No, the doctor is going to weigh several different factors. Factors involve the person is dealing with, what's the best treatment approach? Is this basically extremely severe pain that the person can't manage? Is this a person that is financially basically having difficulties, etc.? All those things we weigh. In other words, it is about you looking at you as a person in terms of managing, and not just looking at the illness. We're not going there to judge you up, etc. Right? So basically, it's about managing you. And management of you is concerning the pain that you're experiencing, the reason why you're experiencing the pain, and helping you get along in terms of managing your pain, both in terms of society, both in terms of your occupation, and for some of those, in terms of spiritual or religious, if you want to entertain that. Now, stepwise, if you're dealing with like mild to moderate pain, because the surgeon is going to stage your endometriosis, they have staging protocols, and Dr. Barker and I see good Dr. Phillip will also be able to highlight these two as well. So starting off, simple things. If your pain is mild severe, we use what we call non-steroidal anti-inflammatory drugs. You all know these more as Cataflam, ibuprofen, naproxen, etc. Over the counter, basically, these drugs for painkillers. However, the great thing about them, is that they're very good at working, in some cases, in managing people with mild to moderate pain, because one thing to realize with endometriosis, they produce these chemicals that these so-called drugs can block, right? And as I say, most of them are simple. You don't have to be fooled by brand names. You can get a very good generic name drug, and it works. What I like to tell people, however, is that when you are buying drugs to manage your pain, recommended by the doctor, that basically make sure you're not crossing the drugs with other drugs. In other words, a person will go and buy diclofenac, and then they'll go and buy Cataflam, and they'll take both of them, not realizing that diclofenac and Cataflam are the same drug. It's just different names, but the same drug. There's also paracetamol. Now, there is a Barbadian culture, it does extend beyond these shores, where everybody think, my daughter always give me paracetamol. Panadols is the one they use. Panadols is brand name. Paracetamol or acetaminophen is the actual drug. Now, believe it or not, it's not a bad drug. The great thing about paracetamol is that it does help in mild to moderate pain. But one of the mistakes, and I preach this a lot, that people make, is that they take it with food. If you take paracetamol food, it is not effective. However, the NSAIDs, the ones I mentioned before, Cataflam, ibuprofen, etc., they must be taken with food, or else they will burn your stomach to a degree. All right? And that is some of the issues we have with these pain relievers. The other one, of course, mentioned, remember, endometriosis relates to hormones, and that's why you see hormonal treatment. Your gynecologist will mostly be employing those. Then you have other drugs, which you may take, but doc, they work me up for antidepressant. Then take them mad. But, and in relation to Jenkins, I bet you 3/4 of them here don't even know how the name Jenkins arrived for the psychiatric hospital. Y'all know where it came from? Pardon? That was the original name of the plantation. Yeah. So that's why you're going to name Jenkins. If I stand for anybody here to challenge me on that? So we use antidepressants. Now, we don't use antidepressants in the sense of it being used for people that are depressed in this particular case. Antidepressants find use in terms of pain relief. There is, of course, the element of depression, and there's good reasons why people are depressed. Because if you're suffering severe pain all the time, as mentioned before, it impinges upon your social life, it makes you feel restricted, you're going to contract your behavior, etc., you can feel depressed. But in the case of the antidepressants, we use such a small dose, it's not at the level that we use for depression. And these sometimes can help in severe pain too as well. And then we also mentioned in terms of anticonvulsants, we're not using them because you have epilepsy. Again, they also have pain relief along with them. Stepping off of the drugs, we bring in also sometimes the physical therapists as well. The reason being is that endometriosis in itself may cause pain, but it also causes pain because of some of the effects it leaves behind, because it causes scarring sometimes. And when it causes scarring, it can attach to tissues, cause tissues, the muscle tissues, for example, to create their own pain syndrome to a degree. So outside of that, people have realized that when they use like meditation or certain physical exercises, they sometimes can take their mind away psychologically and relieve themselves from the pain. Trigger point injections, that relates again to sometimes that can occur because the person's In your pelvis is a whole series of muscles. If they're irritated, they become tense, contribute to pain, and sometimes you use trigger point injections to relieve it. Interventional blocks, again, is a series of injections. This is not a blunt surgery, but using these strategies, hopefully that you don't need to extend surgery. Or they may be employed sometimes after when people receive surgery to a degree. Neurostimulation is much more complex. That's basically using electrodes to stimulate your large nerves, take away from pain, and psychotherapy. Psychotherapy is something, believe it or not, and again, like Dr. Barker on this, employing earlier than later is very important, because you will find that when people use their own psychological, believe it or not, your brain produces its own painkillers. That's the way that painkillers like morphine works. That's the way, like, for example, believe it or not, cannabis to a degree work, because you have receptors in your body that are stimulated by your own substances you produce to turn down pain, all right? Even though, as you said, you may not even realizing that you'll be generating certain chemicals that cause you pain, but you're going to be ignoring it for different reasons. That's because your brain now is being stimulated differently, and it releases these chemicals to block that pain you're receiving. But if I point it out to you, you probably start to realize, you know, sometimes I feel uncomfortable, I need to move my butt cheek to the left or to the right. What can I say? I think pretty well. Non-hormonal drugs, which we mentioned before, basically just some things to highlight. To get away from the issues with the stomach, there's usually one they call the COX-2 inhibitors. These are a bit more friendly on the stomach than the diclofenac and ibuprofen. You have to watch it, because if you overdose on these medications, and you're more prone to overdose sometimes, because when people get a lot of severe pain, they say, I have to take an extra tablet and take on another one and another one and another one. The thing with these drugs is they have what we call a ceiling effect. It's like this. You're not going to go past that, right? So even if you take more drug, it is going to reach this level. That's what the drug can reach, and that's the more appearing it cannot go through the roof. It doesn't go anywhere. So when you overdose, you actually go into the realm of causing yourself more harm than actually benefiting, just to mention. And it's also associated with paracetamol too as well. You have to watch if you overdose. Usually recommend about, people say 4 grams per day. Usually take 1 gram every 6 hours, which is like 4 times a day, and that's the max. Using excessive more is not going to help you. The hormones. Now the hormones, I usually see the realm of, again, the gynecologists. These are like, you closest you relate to is when you come to the oral contraceptive pills. They contain hormones that your body basically produces. It's just some of them that we make ourselves, as opposed to depending on the body. And the key thing is that you use these for is to turn off the endometrial stimulation. If you could turn off the endometrial stimulation, then the person is less likely to experience pain. And that is the aim of these drugs. So the different approaches is that what you use is, for example, we use these things called progesterones, which will turn down the stimulus of the endometrial tissue, or we approach it from turning off the estrogen, which stimulates endometrial growth as such. So basically you realize if when a woman's pregnant, she's not going to get endometrial pain as much. I stand to be corrected on that. Likewise, when she goes to menopause, her endometrial pain will start to decrease, because the stimulation for the endometrial tissue is sort of going to be gone. And then in the cases with surgical approach, what they would want them then, depending on the extreme, is that they will remove, sometimes in some cases, the ovary, etc., and that also reduces it. Just a quick case. Anybody know what hysterectomy means? What you call it hysterectomy? Exactly. Because back in the day, they thought that hysteria came from a woman's womb. And back in the day, it did actually. Because, before y'all get up, because what happened back in the day, women, after they became pregnant and delivered, they used to get an infection, and it used to drive them. Of course, one of the effects of sepsis is that they become delirious or act crazy. So because of that, it was actually true the hysteria that came from the womb, because it was an infected womb. That was back in the day, that's why it was named hysterectomy. So no, it wasn't me, narcissistic. Hormonal drugs, again, if you mentioned those before, I won't bore you all of those, because, I mean, in reality, trust me, although I'm in medicine, they bored me heck to read those, so I ain't really checking for those. But just to mention, these are the reasons why we give you the hormonal drugs, basically to turn off the stimulation of that tissue, okay? You don't feed it, it's going to die, and hopefully it decreases the pain, all right? They got different ones. These ones are more like androgenic, the danazol and stuff like that. Some people may know them from offhand as such. The thing with these two as well, what they would do also, as I said, you're suppressing the so-called activity for the endometrial growth, but they also have their side effects. I also mentioned the side effects in this. Unfortunately, for those that are predisposed to acne, it might aggravate the acne, make you feel a bit more sweaty, it may affect your libido a little bit too as well, increase hair growth, a bit of hair growth loss too as well. So these are some of the things, unfortunately, you may experience, especially with these ones. However, as science advances, they'll be aiming to get better and better drugs. In this group, the gestronome is supposed to be a bit better than danazol in terms of you want to get as much of these so-called androgenic, and when we talk androgenic, it's more like androgenic, it's like the only lines of like man-like features, right? You have to, of course, avoid them if you're pregnant. We don't want you to be pregnant when you're on these drugs. Dr. Barker, correct me. The problem with it is that if you're on these and you're having a girl child, as we may like to say, it can become paralyzed, or as I put it in simple terms, the child will look like mannish when it's born. So it will paralyze the child or make a female more look malish. All right? So you avoid these drugs as well. There have been associations with the risk of ovarian cancer, but they have said that basically in some of these cases, the endometrial, some people believe that in some cases, people that suffer endometriosis, that they're more prone to ovarian cancer anyway. There's also benign liver tumors, in other words, liver tumors that are not cancerous in terms of spreading around the body, that may be associated with some of these drugs too as well, just to mention. So what they did, they moved now to another one. Hopefully not taking all your thing. These drugs stimulate part of your brain, because in part of your brain, especially a little organ in your brain, produces these hormones that lead to the production of hormones further down the chain around your ovaries. And of course, then these hormones coming from your ovaries, estrogen, etc., is what stimulate the endometriosis. So what these scientists have done now, they went up to the brain and said, let me block up there, higher up, and see if we can have a better effect up there, and hopefully get less side effects from these drugs. All right? So that's why you got these other drugs that are coming into play. That doesn't everything, forget that. So Dr. Barker, I know Dr. Barker especially, I'm sorry I'm calling his name a lot, is because we went through university together, so it's easy for me to call his name, basically. So it's that little bias there. But I know especially the team here, they will follow the same lines of protocols and guidelines that they will also modify accordingly, because at the end of the day, they will adapt it or formulate it to you. But just for you know, some people have these so-called algorithms that they will follow. So we'll go like a stepwise. We start with this first, these simple drugs. We start with this simple therapy. You're failing that, then we extend to another one, etc. We go down the lines, right? So don't be surprised if sometimes we present for treatment and the doctor says, well, that treatment didn't seem to work, I have this other treatment. It's not that we just running you down a road, etc. It's one that is already being, in terms of best practice medicine, that's being outlined, right? So people may use this simple one as a stepwise. The NSAIDs fail, then you start to employ the hormones, but the hormones will be more expensive, contribute more side effects. So you start that more down the line rather than that first line. We mentioned about the antidepressants and the anticonvulsants. I said don't fear if they're employed. The key thing is that whoever is your medical professional, they should be open to discussion with you and continuous open discussion as well, so they can explain to you. So it's not really thinking. In fact, I like to say, there's a saying in Barris that it's all in your mind. You ever heard that? The truth is, pain is in your mind. It is your mind. Take off your head and tell me people feel pain. So for you to register pain, you have to have, it has to be your mind. Your mind maps out everything. And proof of putting, I'll tell you just quickly, like this morning, I was dreaming that I was apparently on top of the White House, and I fell off, and I heard a scream, and I was falling. The key thing is your brain is so well, has like a program, so you can feel things inside because of your brain, you see things, you smell things, etc. And your dreams is proof of that. So although these doctors don't see these things do exist, and they're not made up. It's because your brain sometimes is affected by certain, although it seems like healing tissue, your brain registers it, and it's because of that tissue when it was healing, it stimulated or formed a memory in your brain and keeps it going. So sometimes these so-called drugs that we employ actually have to turn down sometimes those so-called wind up or those so-called activation of centers in your brain. So that's sometimes why we give you drugs that don't sometimes act exactly at the site, like how the NSAIDs would, or your diclofenac, but will actually act more at the higher level to suppress the lower level. Someone okay, or? Right. Physiotherapy I mentioned, I can run through quite a thing, I busy to run another time. Just to mention, surprisingly, I took by surprise when I was overseas in my training that they actually was doing acupuncture. I actually had it done for myself, again, not in relation to endometriosis. And I do find in some cases it does work for some people. As I said, some things work for some people, some things do not. That's why you also got to be careful in terms of people will say, oh, this is approved by, in America, they say the Food Drug Association, this is not approved. Everything does not work for everybody. All right? So sometimes it takes a trial, but acupuncture have had good support. Next to it is this thing called TENS, sorry about that. Transcutaneous, basically electrical nerve stimulation. The principle behind it is basically what it's doing is it acts like a gate. Along comes pain, the stimulation is the electrical activity. Electrical activity fools the nerve. Basically, you're feeling knee buzzing, but you can't feel the pain coming. Proof of the pudding, if you get itch on one side of your body, let's say your left foot or your left leg, scratch the other side and scratch it and tell me if you're feeling the pain on the other side. Your brain actually shuts off that pain and focuses on the other area. So that's works. Sometimes, can't say for everybody. Psychological is what was mentioned before. I'm not going to step on that. Involving cognitive behavioral therapy, etc. They employ. Even moving to the part of one of these things called bad feedback. Bad feedback is whereby you stimulate the area, or the person can focus on the area. They see an actual physical response. So basically, when the more they relax, etc., then the activity on the monitor that they're using will change. And then they get in the mind of how they can then modify their behavior to decrease the pain that they're feeling. I like this area, interventional blocks. They work sometimes. On the far side is one that can be gastric, because a whole series of nerves from around the tubes in the pelvis runs to these areas, what we call it plexus or bundle nerves. We put in an appropriate agent that blocks it, a drug that blocks it. The other one is what we call it, it's basically a ganglion empire block, which is lower down. So people that are experiencing pain from the pelvis areas, you can go in sometimes and place that in there. And it's all before you reach Dr. Barker and Dr. Phillips. So, and just to mention, there's no caveat with this. I'm not saying I'm an advocate for marijuana and that other countries making millions of money and we desperate money, but what I would say on the part is that there is research that has shown that basically there's an association between the endometriosis and what they call the endocannabinoid system. The endocannabinoid system is your internal system, your internal system that relates to basically cannabis-like drugs. So I'm not surprised that when they did a study in Australia, when they did a survey, they found that people that were doing self-management for endometriosis, one of the things that they mentioned they had liked using was marijuana in terms of the management of their pain. That is, I'm not saying I condone the practice, I'm just saying that was a study that came up. So I will end off there and hand over to the chair. Thank you very much.
As you mentioned, endometriosis patients, you have the endocannabinoid agent, but it's very low as well. So I just wanted to add that part.
Which is true. And just to add, there's a funny thing with cannabis, etc. And I want to mention this because when I was practicing in another jurisdiction, and in this jurisdiction, I'm allowed to prescribe cannabinoids. And people will come and ask for it. But what people have to understand, it is not an answer, it's not a cure-all. It works for some people, yes, and some people it does not work for. And the reason is the endocannabinoid system, basically the system that is affected by the THCs, the cannabinoids, etc., the cannabis, is very complex. And sometimes we don't understand why in some particular case it will work here, and the other case it does not. It's very complex. So as I tell people, that's why a lot of people, you'll see the doctors' degree have not jumped fully on the bandwagon. But personally, if you exclude me from the profession, as I said, I can understand why sometimes people will consider it as part of their armamentarium in terms of management of their pain. But just to let you know, it's not hardcore that it works, etc. And it does carry side effects to it as well. Cannabis has side effects. So there's nothing that we do that does not have side effects. Okay, so let's know that. Anyone? Well, I was just saying, questions, you use more water.
Question.
Yes, sir.
How important is that, what role is that in terms of being managed?
Oh, well, now they found in some studies, I can relate this to, like, for example, fibromyalgia, which is one of these complex ones, a complex pain syndrome. And they found that basically pain studies is managed by that in some cases. Some studies support that. But coming into the pelvis, I was reading actually one of the studies that was related, and Dr. Barker corrected this, was vestibular dynia. And basically a pain that women experience is between, and it's basically located on the vagina, and they can have severe pain. And one of the things that they were recommending in terms of that is avoiding certain foods high in oxalates. And these foods are like spinach, for example, tea, cocoa, etc. Apparently, they were saying that these oxalates somehow cause some reaction in the vestibular part of around the vagina and is associated with pain. So they encourage people to decrease these foods in terms of the management of their pain. I can't think of many studies support that, but that is what they were highlighting. But just to put on, don't forget, and I've seen where people support turmeric, for example, as use as in pain relief. So I can't knock these things because aspirin, right, which some people use for pain. Aspirin came from willow, and years ago people would take willow, for example, and use willow. In the case of the people that got irritable bowel syndrome, they will use peppermint oil in terms of their management.
I wanted to ask about, you spoke to mild to moderate pain, but not severe pain. So we saw the ibuprofen and the paracetamol, but what happens where, and it's a teenager, started on the heavy stuff because pain is so severe, and now it appears is building up a tolerance to the heavy stuff. Then what happens?
Right. So basically, I would expect that this person would be presented most likely to their gynecologist, who would weigh different, as I said, they would have sort of an algorithm or plan set up based on the person, basically. So you may implement, as I said, stepwise. You may start with the NSAIDs, see how they manage, etc. And then you extend up to the more powerful things like the hormones. And if the doctor thinks necessary, then they may proceed, as I said, standing correctly, proceed towards more laparoscopic investigations and other, maybe more definitive management. So it all depends on that person, because at the end of the day, it is your choice how you want to progress to as well, right? So they will move in that sort of stepwise, and that's how he's trying to put it there. Some places will use more powerful agents. They're not as well indicated, and I didn't mention it on purpose, the use of opioids in terms of pain, because sometimes the side effects associated with them is not as beneficial. So they're not as employed. So basically, if the simple over-the-counter drugs are failing, if I mentioned that in terms of discussion with the gynecologist, they find that if you use the antidepressants and the anticonvulsants are not helping, and the hormonal therapy is not helping, then they will make that decision. But as I said, sometimes it's up to them how they want to make the maneuver as such. But it takes a coordinated team. The psychologist being important, the physiotherapist being important, as I said, depending on if the other tissues are being affected, because it may not be a simple thing of this endometriosis. She may have another issue that is causing the pain as well. So you may have to pull in other specialists. For example, I saw a girl that had endometrial deposits related to her ureter, and she was having that bleeding, etc. and pain. So we had, of course, involved the urologist in her management. Yes,